We're talking about cranial nerves today, and there are four questions you have to ask yourself, I guess, with almost anything you do. Why are we doing it? When do we do it? What do we actually do when we find a positive or a negative result? And then how do we do it? So we're going to look at answering those four questions now. I once reported my findings of a cranial nerve exam to a family physician. I got an extraordinary response from her. And basically it said, why am I doing that? It's not my job, and it's her job, regardless of the fact that I was giving her positive results. And my response was, well, it is your job, why didn't you do it? So what we're looking at here is very pathological ego, and ignorance, complete ignorance of what we are doing and what we're supposed to do. And also that's crowned by a really unhealthy dose of arrogance. Why should we do it? For the same reason we look at nerve roots and spinal cord, to make sure there isn't a problem there. And when there is, we can report that problem with reasonable data. That's why we should do it. More specifically, we're doing it in case there is a problem with the brainstem. Now, for the most part, this is due to trauma or possibly traumatic VBI when we see it and the physician hasn't seen it or has failed to recognise it. The exam should be done when we think it's necessary. And personally, I think anytime you're going to manipulate the neck, a cranial nerve exam should be done prior to every single manipulation. So it's a routine thing every time the physician visits you if you're going to do something that is risky. I can't see any reason why we shouldn't do this any more than we should do myotome dermatome exams. This is not the exclusive province of the physician. None of it is. We have no exclusive provinces neither. You do what you need to do for the well-being of your patient, and that's it. So that's why we should do it. Most signs can be interpreted in the context of the history and other signs, but central neurological signs are not able to be interpreted by you. If they're present, they're present. If it hasn't previously been diagnosed, then it needs to be diagnosed. So if you have positive tests, central neurological tests, they should be referred to the physician. The question is, how are you going to refer them? Are they going to go back to the GP, or are they going to go to the emergency room? If the tests are negative when there are no symptoms present, that's a different situation to when they're positive when symptoms are present, and only when symptoms are present. The first one is, or they're positive all the time. So basically, if they're present all the time, this is a stable brainstem syndrome in this case for cranial nerves. But if they only come on when the symptoms are present, the non-neurological symptoms in particular, then they are unstable, and that's a more dangerous situation. If we're looking at VBI or possibly compression of the spinal cord, then these instabilities, these unstable signs where they're present only when symptoms are present, are more dangerous. They should certainly go to the emergency room. Signs that are stable are probably not going to worsen in the short term. So you can give some thought to referring that back to the family practitioner or specialist, whoever sent it to you. If they can't get in quickly though, back to their GP, then they should go to the emergency room. Whichever way you do it though, these positive signs need to be further examined and then interpreted. And we haven't got the knowledge, and we haven't got the resources to do that. This is the physician's job. You get them to the physician and let them do their job. Referring back to the idea of an unstable brainstem signs and symptoms, if the patient is asymptomatic and they have a negative cranial nerve exam, it doesn't mean to say that the examination is going to stay negative when they're symptomatic. So, for example, if we're looking at VBI, which is mostly why we're doing the cranial nerve exam, if we're looking at VBI, when they're not dizzy or having headaches, they may well have no neurological signs. On the other hand, you need to test them when they are symptomatic, that is having dizziness and headache. If they're getting neurological symptoms, the cranial nerve test is really not necessary except to provide more information to the physician. But assuming these are not hard neurological signs, then the cranial nerve exam may now be positive. So it's important that you test it both when the patient is symptomatic and asymptomatic. Now, if the test is negative in both cases, you can be fairly sure that they don't have a brainstem syndrome. Fairly sure, but everything is always about probabilities, so you can't be certain of this, but you can be a lot more comfortable that there isn't a central neurological problem going on in that patient. And finally, the how. How should we do it? Well, you should do as much a comprehensive examination as you possibly can, which includes subjective and objective, obviously. But the exam should be fast. Nearly always, you don't have a medullary, a brainstem syndrome going on in your patient, so you don't want to spend hours doing this. And you can get this done. The objective test can take 90 seconds if there's nothing much going on. Of course, if there is complications and you are seeing what may be signs, then that exam is going to be longer. Rightly so, it's going to be a longer exam. But generally speaking, if this is a negative exam and the patient is reasonably cooperative with you, 90 seconds is about all it takes, much less than doing a scan looking for myotome, dermatome reflexes. So there's no reason not to do this at all. Time isn't really a factor here. So what we'll do is we'll look at the subjective first, and then we'll have a look at the objective exam afterwards. Okay, so looking at each cranial nerve and the more common symptoms from it. The olfactory nerve, cranial nerve 1, the patient may complain of lack of smell, anosmia. It's rare and it's usually not traumatically induced. Parosmia is more common, and it's an illusion of smell, basically. So they can imagine this, a smell of burnt toast, feces, cedar chippings, and so on. But there's an illusion of a smell there. If illusion is the right word to use with smell, not sure. Scintillations, flashing lights. This is more common than actually blind spots, but the scintillations are seen in the blind spot. So you think about this as denervation sensation. This is replacing the blind spot. So depending on the size of the lesion and exactly where it is, this can be hemianopia or quadranopia with scintillations. Rarely do they know that there's a blind spot unless it's covering a large portion of the eye or the central area of the eye, because you tend to move your head to look at the periphery rather than look straight ahead and see if you're blind or not. Cranial nerve 3, diplopia. Double vision is because basically one eye is paretic and you're getting two images forming and you're not able to join the two together, merge them, so you see double. And you can actually test this on yourself. If you push through your eyelid on one eye and just push it medially or downwards, you'll see that your vision doubles, either on top of each other or by the side of each other. This is diplopia. They'll describe it as blurred vision, but you can check easily enough to see if it is diplopia. Just close one eye and it'll become a single vision, and you can do the same with the other. Because of the control of the pupil, they can get photophobia because of the dilation of the pupil, so bright light can be painful. And they may see ptosis when you don't. So it depends on how bad the ptosis is, but this may turn up when they're fatigued, and this is what they may complain of as well. But generally speaking, with third nerve palsy, that ptosis is fairly large, so you can see it as well. Cranial nerve 4 is diplopia again. 5, facial paresthesia. It's going to be hemifacial, or it may be a spot of an area, a patch of paresthesia. Again, the paresthesia is, in this case, will be denervation sensation. So you should check their sensation, pinprick or light touch, and if there is a spot that they're complaining of that's not half the face, compare that to the other side as well. There may also be some dysgeusia here because of the taste sensation alteration. because this supplies the epithelium of the tongue, and you know what it's like in the dentist when you have an anaesthetic there, local anaesthetic, you can get that metallic taste in your mouth. Well, that's dysgeusia. 6, abductions rather, is diplopia as well. 7, it does taste for the tongue, so dysgeusia is possible there. It also controls the stapedius muscle. So if this is paretic, the muscle cannot pull on the stapes and pull it up against the other bones, and so make them more rigid. So high frequency, high decibel, or very low frequency sounds can become amplified because of that lack of attenuation, and that can be painful. There may be facial asymmetry reported by the patient again, although with upper motor neuron symptoms, this is much less noticeable than with lower because of the increase in tone. But that facial asymmetry, again, depending on how bad the problem lays, is this can come on at certain times when the patient's tired or other conditions, so they may report it. 8th, vestibular cochlea. If we look at the cochleal part, if we look at the auditory, the cochlear part, it's going to be some form of dizziness. So it could be type 1 dizziness, which is vertigo, type 2, which is presyncope, that lightheadedness, or it could be type 3, which is ataxia. Generally speaking, if you're getting severe vertigo, then you're going to get the other two following it or during it. They may also complain of blurred vision because of nystagmus and retinal slip with the vertigo. So that's another possible symptom here as well. It's an indirect one though. 8, the acoustic, they can have hypoacusia. Most people don't believe they've got hypoacusia. Basically they think their wife is just sort of telling them that they're deaf because they're not listening to their wife. More likely they're going to have tinnitus. High frequency tinnitus tends to be associated with sensory neural, that is neurological deafness, while low frequency tinnitus tends to be conduction type deafness, air conduction type deafness. Dysphagia, dysarthria and dysgeusia for 9. 9 is a bit of a strange one. 9, 10 and 11, they tend to be mixed up a little bit. So essentially sort of separating these out to make it a bit easier to understand, but there's a lot of overlap here. So for the glossopharyngeal, there'll be dysgeusia because again it's a major taste tensor of the tongue. Dysarthria, the soft palate uvula can be paretic, and this can give you a certain amount of dysarthria, and also because of the soft palate and so on, you can get dysphagia from this as well. 10, the laryngeal muscles can become paretic or paralyzed, and so you'll get dysphonia, which is a hoarse rasping sound. You can also get this with 11, the nucleus ambiguous part of 11, and this can also affect the tongue muscles. So again, this is all mixed up. As far as the other part of 11 is concerned, this is sternomastoid and trapezius. Now, sternomastoid is innervated by both hemispheres. One decussates and the other hemisphere doesn't. So it makes it less sensitive to change. So you won't see the asymmetry so much with the sternomastoid as you may do with the trapezius. The trapezius, particularly with lower motor neuron lesions, can give you a lot of atrophy there, and actually it can look like hypertrophy because the first rib now stands out. It looks massive compared to the other side, but if you feel it, that's not the muscle, that's a rib. So you may see trapezius asymmetry here. And then 12, tongue, so dysarthria and dysphagia because the tongue makes a bolus of the food, and if they can't do that effectively, then you can have dysphagia. So these are the symptoms, and with vertebral artery problems, these are not new. These are not symptoms that come on early in the problem. Typically, these are delayed onset. These heavy, hard neurological symptoms tend to come on much later. Even with a full-blown stroke, these tend to come on later on.
2, 1.
Okay, 1. So we're going to close out one nostril, shoot out your eyes, piece of soap, unscented soap, identify the smell, and then close the other one, identify the smell. Don't ask me if you can smell it, Alison will identify it. Soap's good. Confrontation test, keep looking in both my eyes there, bring it in, see that, and you're going to bring this in from the outside in as halfway between you and your eyes are level. Cover up one eye, and I'm going to bring target in from this side, the blind side. She tells me when she sees it, and the other side, there, and there, and there, and then we'll trace out the area that she doesn't see. So 3, 4, and 6 tracking for the extraocular muscles. About 18 inches away, fairly slow track, follow, and you get a letter H. It's a standard one, and you're looking for paresis, paralysis, nystagmus. 5, trigeminal, sensation. Keep it very close to midline. You can use pinprick or light touch. There. And if there's an area of paresthesia, test that separately against the other side. That brings us to 7, smile, frown. Good. So if this is central, you're going to lose the smile, keep the frown because of decalcations. And if it's peripheral, they'll lose the smile and the frown on that side. 8, can I swing your legs that way? Vestibular portion is stabilise the back of the head and the trunk there, and you're going to move them backwards and forwards without the neck moving. So we can do backwards and forwards this way, there, and you can even go in circles. Okay, nice big movements. And you sit them this way so you can put them back on the bed if they lose it. Swing away, around. Auditory portion, the cochlear. Yeah, okay.
Oh, take it.
Okay, cochlear, close up the ear, hum. Do you hear that in the middle or one side? More on the right. So she's deafer in the left ear. Can you hear that? Equally? More on the left. So you're deafer on the left there from humming. So you hear it better in that ear. And you've lost your hearing on that side.
No, this is like more pronounced.
Okay, but you hear the humming on that side more as well. I have no idea what the hell that is. All right, I can't even think about it. Generally speaking, though, if the hearing is completely lost on one side, bone conduction, air conduction, that's going to be a sensory neural loss. If the hearing is lost on one side, but bone conduction is better on that side, that's a peripheral conduction loss. I have no idea what's going on there. 9, we're not going to test. That's a gag reflex. But you can look at the uvula, and it sort of gets into that area as well. Open your mouth, look at the uvula and the soft palate, they say and you're looking for the soft palate and uvula that goes straight up. If it gets pulled off to one side, that's the strong side is the side it'll be pulled to, the other side is the weak side. 10 is dysphonia, can't test that without a laryngoscope. 11, shove your shoulders up for me, up there, hard as you can, and you should be able to break that. Okay, given that, we can then do a reflex, use a reflex hammer like your fingers, and you tap into the front there and you look for the contraction there, and you can actually look for it's chronic. All right, so that's 11. Stick your tongue out, and you're looking for it to deviate to one side or another. It will deviate to the weak side as it's being pushed over that way by the strong side. Okay.